All right, everyone. Thank you for joining us tonight for the next chapter of the Renew sessions. This one is to be focusing on hereditary cancer and your family tree. My name is Sarah Muir. I'm a genetic counselor with the Windsor Cancer Genetics Program. We do serve all of the Erie St. Clair regions. That includes Sarnia, Chatham, Windsor, and the surrounding neighborhoods. You might typically be used to speaking with Shannon or getting communications from Shannon. She can't join us for tonight, so I'll be acting as both the speaker as well as helping with the introductions and going over some of the housekeeping details. And just an introduction here. A few housekeeping items. Reminder that this session is being recorded. And you may ask questions. I do ask that you please hold your questions for the end of the talk. That way I may answer some questions as I'm speaking and going over some topics. But at the end, we will have a question time. If there's any questions, you're welcome to unmute and speak, or if you'd like to use the chat, that works for us as well. A recording of today's session will also be available, as well as the accompanying slides and a feedback form. All of these will be sent to you next week. Please do fill out the feedback form and send it back to us. It is helpful so we know how to best do these sessions for what people want to see. And if you have any additional questions, you're always welcome to email the Renew program at renew@wrh.on.ca. Okay, so through our time tonight, I'm hoping to cover four main topics. I want to review some basics about genetics and cancer and how those things go together, highlight family history that makes us suspicious for a high risk, and what I mean by that, and give you tools to collect and understand your family history, looking to identify some of those red flags you might see, and giving you ideas for when to talk about genetic testing or genetic counseling with your providers to see if that's something that might be a good idea for you or a family member. Okay, so before we begin, this is just an information session. My goal is to share in general information, nothing specific to anybody's particular scenario or their case, and really just giving you those tools to know when to seek a formal genetic counseling appointment or genetic testing with your provider. No specific recommendations for anybody will be given today. And this is not meant to replace a formal genetics appointment, as I mentioned, or make any recommendations for you. Talk to your doctor if you're interested or think you might be eligible for anything we talk about today. Okay, so genetics. I feel like everyone has some concept of genetics, even if it's just when a baby's born, saying it looks like the father. What we're going to get into is a little bit more in depth or a bit more of an explanation. So to go over some background information, the human body is made up of millions of cells. Inside cells is your genetic material, which is packaged into these structures called chromosomes. Chromosomes contain the DNA, our genetic material, and pieces of our DNA make up genes. And genes are really the instructions for how the body grows and develops. So that's eye color, hair color, shape and function of your heart. These are all things determined by your genes. And we have over 23,000 genes in the human body, and these genes do a variety of functions. So go over some basic inheritance principles. We typically have two copies of each gene. One copy we've gotten from a mother or an egg, one copy we've gotten from a father or a sperm cell. And that means we have two copies, and when somebody has children, they pass on one of their two copies. And it's through passing on of these genes that family traits can get passed down, whether it's a characteristic of the family like small ears, a big nose, or sometimes an increased risk for certain health conditions. And in this picture here, we can see exactly that. The two individuals are the parents at the top. One has two blue genes, one has two green genes, and their son or their child inherited one blue and one green from each parent. Okay, so the question is, well, how do genes and cancer relate? And the question is, or the answer is, cancer is caused by DNA damage. And DNA damage can occur from a variety of factors: the environment, some things we can and can't control, natural aging process, smoking, so that's something that we can control, our exposure or lifestyle choices to smoke cigarettes, for example, radiation exposure, which could just be natural sun radiation or potentially even radiation from other treatments. and other lifestyle options. All of these factors can lead to DNA damage, and it's something that happens and we can never completely avoid. It is part of being human on our planet. So typically, we have here a normal working gene. And we can think of genes as really the instructions for something. And these genes, when they work, they're instructions, and a protein is almost like the worker that's carrying out the instruction. We have a normal protein, and the normal protein ensures our body cells are healthy and controlled. That is what is typical or what's expected of the body. The problem can be when there's a spelling mistake in one of these instructions, what we call a mutation in the gene, which means this instruction, it can't be read properly anymore. So the working protein no longer works properly anymore. It can't read the instruction. It doesn't know what to do. So that results in the protein not being able to do its job. And that's what can lead to uncontrolled cell growth and division, which is the basis of forming a tumor and cancer development. So to break it down a little further, up to 85% of cancer is what we call sporadic, meaning it just happens by chance or combination of risk factors like we talked about earlier, having to do with lifestyle, environment, natural aging. And that's the majority of cancers. About 10 to 15% of the time, we might see familial cancer risk. And this is where we might see cancer more than we expect by chance alone in a family, but we don't find anything with genetic testing. And this could be that family members, they often share the similar or same lifestyles or environments, which can lead to an increased risk for cancer development. And this is why we might see a trend in a family sometimes. We also see hereditary cancer about 5 to 10% of the time. And this is what we focus on thinking of hereditary genetic risk and genetic testing. And I do want to specify here, I don't mean cancer is hereditary. You can't pass cancer on, it's not contagious. What I mean is hereditary risk for cancer, passing on an increased risk through your genetics. And that's what we'll focus on today. And that's the question really, is how do we determine who's in that 5 to 10% category? Okay. So, and that's where it comes all down to our family history. Your aunts, your uncles, your siblings, your children, all of these individuals and their health history can be clues into what we might expect for your risk or your chances of developing health conditions, including cancer. Oops. Uh, because, for example, knowing of the cancers in the family can be helpful. If you had a great aunt who had a breast cancer, well, that relative is a little further removed from you, so less of an impact on your risk. But if you say two of your three sisters all had breast cancer, well, you know what? That certainly raises our suspicion. Maybe there's something going on in the family or this increased risk. And the Ministry of Health also has criteria in Ontario when there is genetic testing that's funded by OHIP based on who's most likely to or at a greater chance of having a hereditary genetic risk for cancer. So for the next chapter, we're going to go over features of hereditary cancer and family histories. So there are really 5 main aspects of a family history that we look for, analyze. One of those is being age, because as some of us may be familiar, unfortunately, as we get older, cancer does become more common. But if we see cancer diagnosed at unusually young ages, that could raise our suspicion. We also look at the types of cancer because some cancers are more common than others, and some, like ovarian cancer or specific types of ovarian cancer, might have a greater chance of having that hereditary genetic factor compared to other more common cancers. We also look at if anyone in the family has had multiple primary cancers. And what I mean by that is not cancer that's metastasized or spread to other parts of the body, but really an entirely new second cancer diagnosis. And those two things are very different when we think about risk for a hereditary genetic condition. We also look to see, are there multiple generations affected in a given family? Because if we see the same cancer or similar types of cancers over many generations, seeing a pattern, that's when we get a little more suspicious. Versus if it's just one generation affected, it could be more thoughtful of something else going on, maybe a similar environment that those individuals were in. We also look at the ancestry or ethnic background or background. And this just gives us an idea because certain backgrounds or populations have a greater chance of certain genetic conditions compared to others. Okay. So to go over a few examples, this is what a sporadic cancer family history might look like. So to orientate you to what we're looking at, this is what we call a pedigree or a family tree, where circles represent women typically and the squares represent men. And it looks like my pointer is working, which is great. So this woman circle is shaded in, and that means this person's been affected. In this case, it's noted as breast cancer diagnosed at age 62. Now this woman are attached to these other individuals by this upwards U kind of shape of lines connecting them. That indicates a sibship or siblings. So she has two sisters and one brother. And if we jump over here, this sister is connected to a person with a straight line. That indicates a partnership or a relationship and has led to children, indicating by going down a generation where there's two daughters and a son for this couple. That's kind of how these pedigrees work or how we can use this to share and show information. So with the sporadic cancer, the first glance, we don't see a lot of cancers. We only see one breast cancer in a woman at age 62, which is more typical of a sporadic cancer. It's more of a typical age. 50s, 60s is when women, if they have a breast cancer, that tends to be the more common ages and what we see with sporadic risk, and no other family history. So overall, from a genetic standpoint, this does not look suspicious for anything hereditary, more so that sporadic or happening by chance, a combination of risk factors. This is an example of a familial cancer family. So we do see two cancers and the same type of cancer, colon cancer in this case, which is maybe more than we'd expect by random chance alone in a family. We see it's an individual who's diagnosed with colon cancer at 60, and on their mother's side of the family, an aunt who had colon cancer at 85. Now, again, looking at these ages, both diagnosed middle to later in life, more indicative of that sporadic or non-hereditary type. We don't see any other cancers. Overall, not overly suspicious for that hereditary genetic factor, more so due chance maybe there's a common environment or lifestyle choices for this family. This is what we might expect with hereditary cancer in a family. As you can see, just first glance, we're seeing a lot of shaded in shapes. We can see right here a woman who was diagnosed with breast cancer at 29 and has passed away. That slash going through the shape indicates somebody is deceased. This person had a sister who had breast cancer at 35 and ovarian cancer at 39. So already we're seeing a few red flags. We're seeing young cancer diagnoses. Breast cancer in somebody's 20s and 30s is certainly uncommon, so that raises our suspicion. We're also seeing somebody who's been diagnosed with both breast and ovarian cancer. So that would be two primaries. Again, another red flag. And we can see there are several other relatives in this family with breast and ovarian cancer. So this family history looks quite suspicious. And really, we'd be concerned for a hereditary genetic factor, and genetic testing for this family may be an option. Now, some people might come to genetics and say, everyone in my family has cancer. And while it may feel like there's a lot of cancer in a family, it's really important to take a deeper look into that and really analyze, well, who in the family and how are they related to you and what types of cancers, right? So if we're seeing this person who's a 32-year-old woman, through her father, she has an uncle who had lung cancer at 62. Well, some cancers, like lung cancer, generally are not thought of to have a strong hereditary factor. The greatest risk factor for lung cancer is a history of smoking. So it's usually due to environment or lifestyle choices, not that strong hereditary genetic factor. So really does not impact our patient, the 32-year-old woman's risk very much. On the other side, her uncle, his partner, had breast cancer at 68. And while certainly this woman is a part of the family, she's not a blood relative. She's not related by genetics. So her cancer history really does not affect this 32-year-old because they don't share the same genes. We're not worried about the risk from a hereditary genetics perspective because they're not related. Now, if we go up a generation to our 32-year-old, her grandparents, Her grandfather had prostate cancer at 81, again, diagnosed later in life, and we don't see any other prostate cancer in the family, so not overly suspicious. With her grandmother, again, lung cancer, not a cancer type we're generally concerned about, as well as diagnosed at a later age. And this grandmother's sister had breast cancer at 89, later age, but also this is actually a fairly distant relative. It's a great aunt. And again, the further somebody is related to you, the less of an impact their health history has on your risk. So overall, although it appears, may feel like everyone in the family has cancer, from a genetics hereditary perspective, something like this is really not concerning. Pardon me, everybody. And one thing to know is family history can change over time, and we do see this fairly often. Somebody may initially have a family history that doesn't look suspicious, like on our left here, where the only cancer in the family is this person's mother who had breast cancer at age 50 and has passed away. And that arrow indicates the main person we're speaking of. Overall, looks more like sporadic. We don't see any of those red flags popping up. But 2 years later, this same person may come back and you know what? Now they have a family history where their sister has been diagnosed with ovarian cancer at 44 and their brother has male breast cancer at 42. And men having breast cancer, while it can happen, is more rare compared to something like a female breast cancer. And so these two factors, along with the mother's history, do raise our suspicion that, you know what, this family is starting to look suspicious. We have some of these red flags. Genetic testing for this family might be a good idea to know, is there an increased risk being passed down? Now, I did want to go over a few examples of hereditary cancer conditions. Some of the more common ones are ones that I find interesting, just to give a few examples of what we're talking about when we say hereditary cancer conditions or genetic conditions. So one of the most common ones we might hear about in the media is hereditary breast and ovarian cancer syndrome, or HBOC. And the two main genes involved with this condition is BRCA1 and 2, or BRCA1 and BRCA2. Now, these are the two we often hear about in the media, posters, the news, Angelina Jolie's story, if anybody's familiar, that had to do with these genes. And with BRCA1 and BRCA2, the main risk we see is for women with an increased risk for breast cancer. So for both BRCA1 and BRCA2, the risk is thought to be over 60%. And women who have a mutation in one of these genes, having this increased risk for breast cancer might be eligible for increased breast screening, like more frequent mammograms or breast MRIs even. And some women may even choose to have breasts removed as a preventative option. Just to give you an idea of how genetic testing results can influence recommendations or screening and preventative measures. We also see an increased risk for male breast cancer, and this does depend on which gene is involved, BRCA1 or BRCA2. We also see risk for cancer of the pancreas, between 5 and 10%, depending on which gene we're concerned with, as well as ovarian cancer for women, again, varying depending on which specific gene we're speaking of. And prostate cancer, we also see for men, for both BRCA1 and BRCA2, the risk does vary, again, based on the gene. And having a BRCA1 or BRCA2 mutation, it's thought to occur in about every 1 in 400 people. So while it's not fairly common, 1 in 400, it's not terribly rare either. And one thing I did want to point out is these risk numbers are just examples based on some of the resources that we use when we're quoting some risk numbers. If you're doing your own research online, Googling or other resources, these numbers may appear a little bit different depending on which resource you're using or website, organization, and which studies are being referenced. So it can vary a little bit, but this is just to give you an idea of what the risks could be. And certainly there are other genes besides BRCA1 and BRCA2 that are involved with risk for breast and ovarian cancer. Now, looking for features of hereditary breast, ovarian, and prostate cancer, because as you see, those three cancers can sometimes go together in a family. Let's revisit those 5 things we're looking at. So ages. So if somebody's been diagnosed with a breast cancer at 45 or younger, that's suspicious for hereditary breast cancer and would meet genetic testing criteria based on current OHIP guidelines. Also looking at the types of cancer people were diagnosed with. Ovarian cancer, prostate, specifically metastatic prostate cancer, meaning it's spread outside of the prostate, pancreatic cancer, as I mentioned, male breast cancer, and a certain type of breast cancer, a triple negative, diagnosed under 60. As well as we look to see, is there somebody in the family who's had a breast cancer twice, two separate primaries, one of those being diagnosed less than 50? And are there multiple family members who had these different types of cancers diagnosed? And for background, when we think of BRCA1 and BRCA2, we also look at ancestry in regards to Ashkenazi Jewish, because we know people who have Ashkenazi Jewish background have a 1 in 40 chance of having a mutation in BRCA1 or BRCA2, where the average person who's not Ashkenazi Jewish is about 1 in 400. So you can see there how ancestry and background can play into your risk for certain genetic predispositions or genetic findings. Okay, the next condition is Lynch syndrome. And I just want to say here, syndrome can sound like a scary word sometime, but it's really just a name given to a condition that describes it, and it gives us a specific name to know what risks we're talking about with this specific condition. And in this case, Lynch is just the last name of the person who kind of finally pointed out or identified this condition being a hereditary genetic condition. So together we have Lynch syndrome. It used to be referred to as hereditary non-polyposis colorectal cancer, or HNPCC syndrome, which is a bit of a mouthful. So Lynch syndrome is the more common name and is the most correct name nowadays. And interestingly, Lynch syndrome is the most common hereditary genetic cause of colorectal cancer. And I do want to specify here, colorectal cancer in general, most of the time, not hereditary genetic, right? It is something that just happens sporadically, like we've talked about, a combination of risk factors. But for those that do have a genetic hereditary component, Lynch syndrome is often the most common explanation. With Lynch syndrome, we see an increased risk for colorectal cancer and endometrial cancer, which is the endometrium lining of the uterus. Those are the two more common ones, but we also see an increased risk for other cancers, mainly involving the GI system, like gastric, which is stomach, small bowel, kidney, pancreas, and others, including ovarian for women. And there actually are 5 genes known as the mismatch repair genes that can cause Lynch syndrome if there's a mutation. And Lynch syndrome is thought to affect about just under 1 in 300 people. And depending on which gene has the mutation for that given person or family, tells us which cancers we're concerned about and what amount of risk, because it does vary as well per gene. And for Lynch syndrome, features that we're looking for, is there a Lynch syndrome cancer diagnosed less than 50 in somebody? Because Lynch syndrome cancers can cover a variety of different cancer types, we are looking to know what types of cancers. And we have a list of the different cancers on the right side. Has somebody been diagnosed with a Lynch syndrome cancer and a second primary Lynch syndrome cancer less than 60? And has somebody have a Lynch syndrome cancer also have 2 or more relatives who also had a Lynch syndrome cancer, right? We're trying to identify those patterns or those red flags. And with ancestry with Lynch syndrome, while there can be certain backgrounds or ancestries that might have a greater chance of certain mutations, overall, Lynch syndrome is something that affects every background and population, and no one ancestry or background has a higher proportion of Lynch syndrome in it. It really is just skewing what the specific variants, but overall, everyone would be considered equally at risk based on backgrounds. Okay, now what's really neat is in Ontario, recently in the last few years, they've introduced reflex testing on newly diagnosed Lynch syndrome cancers. So colorectal cancer being the main one, we'll use as an example. And this is something I find really neat, and I'm proud that the government's done this for us. So we have a tumor, right? And a part of regular tumor workup to know what kind of tumor we're working with and how to best treat it, they do this screening for Lynch syndrome. So on a given tumor, we expect to see, if we pretend this is colon cancer, we expect to see certain markers. If the markers are there, great. We're not concerned this is Lynch syndrome. Likely it's not. Maybe it's due to like sporadic reasons or maybe another genetic explanation, but at least Lynch syndrome, we've in a way ruled out, or at least we're not very suspicious of. However, if the markers on this tumor are missing or different than what we expect, well, now we're a little more suspicious. Does this person have Lynch syndrome, which has led to their colon cancer development? In these cases, we might need to do more testing, possibly including genetic testing to identify, does this person have Lynch syndrome or not? Again, it is just a screening test. It doesn't tell us for sure, but just gives us an indication, do we need to do more? Okay, before I go to the next slide, and I apologize if I made that slide go too quickly, I'm going to be introducing another hereditary cancer condition. There is a visual that might be uncomfortable for some. There's no gore or anything like that, but it is the inside of a colon where we see lots of polyps or bumps. So it is graphic in that regard. So certainly feel free to look away. I will indicate when we pass these slides with those pictures. Okay. So hereditary polyposis. So having colorectal polyps or polyposis, having many polyps. Having colorectal polyps is not uncommon, especially as we get older, and having a few is normal. But sometimes we can see more than typical or more than what we might expect. And one cause for this may be what we call classic familial adenomatous polyposis, or FAP for short. This is where we see over 100, sometimes even thousands of colon polyps. And you can see here the image on the right, two images, one's kind of a graphic display and one's a visual. We can see that the colon that's normally all from the inside fairly smooth is just bumpy with all these bumps or polyps. And we can see that in the bottom image very well. It's not what we would expect for a typical colon. This would be considered polyposis. We're seeing many colon polyps. With FAP, average age of onset is 16 years old, which is quite young. Most hereditary cancer conditions do not affect children or minors, usually something more we're concerned about for adult life later in life. Although the average age is 16, we have seen this condition develop with these polyps between the ages of 18 to 24. And unfortunately, if somebody with FAP is left untreated, so these polyps are not taken care of, they continue to just develop and grow. If that happens, it's almost about 100% chance of getting colorectal cancer in their lifetime if untreated. If somebody's being treated and we know about this and we can act preventatively and proactive, that changes. There can be other tumors as well, or different cancer types, and non-tumor findings that we can see in people with FAP as well. What's also interesting about this is most hereditary cancer conditions are inherited from parent to child, right? We see this pattern going through. Sometimes though, we can see a mutation happen brand new in somebody for the first time, which means it wasn't inherited from a mother or father. Something happened brand new in that person and could be passed down to their descendants. And we can see this with FAP. About 1/3 of the time, it's de novo, meaning this brand new mutation for the first time. In these cases, the person has these colon polyps, but they don't have a family history, which can make it sometimes a little tricky because it seems like it comes out of the blue. But again, having FAP in itself is pretty rare, so nothing we're concerned about on a general basis, but just some kind of interesting aspect of genetics. There's also what we call attenuated FAP, which is where we see colon polyps more than typical, up to 100, but sometimes it may just be a dozen or more. We do see colorectal cancer in the family, so we often see family history, but usually older ages of onset more typical, not as young as we see with FAP. And we tend not to see other GI cancers. And what's really interesting is although these two are similar but quite different in their severity, they're actually caused by mutations in the same gene. And it actually depends on what part of that gene is the mutation and what type of mutation, which can help predict, is it looking more like this classic FAP with more severe, or is it that attenuated, less severe form? Okay. Familial malignant melanoma syndrome is also an interesting one. There are really 3 genes connected to having an increased risk for familial malignant melanoma: CDKN2A, BRCA2, which we did touch on earlier, being related to breast and ovarian, as well as CDK4. So when we get suspicious of a hereditary genetic factor for melanoma, maybe if we have somebody who's had multiple malignant melanomas over 3, and somebody who's had these melanomas younger than age 40, and they have a personal or family history of pancreatic cancer. Now, one thing that's tricky with skin cancer, and something important to know, is the greatest risk factor for skin cancer development, whether that is melanoma, basal cell, squamous cell, or squamous cell, is your natural skin pigmentation and exposure to the sun, right? We know people who have more fair skin, lighter hair, blue eyes, they may be indicators as well, are at greater risk to have receive damage from the UV of the sun, which can lead to a skin cancer development, versus people who have a darker complexion or more skin pigmentation. There's a bit of a natural barrier or resistance to UV damage from the sun, so we see less of a risk for skin cancer. And in this map below just shows us a map of how common melanoma is, and we can see in the areas that have sun and a lot of the population might be of more fair, lighter skin, we see a greater incidence or greater rate of melanoma for the people of that population. Now, these are just a few hereditary cancer genetic conditions. There are more rare ones. I don't want to go over anything in particular detail. We've covered some of the main ones or more common ones that we can see, but there are rare ones, and there's going to be certain tumor types or cancer types that might be a red flag on themselves as being connected to a genetic condition. For example, multiple endocrine neoplasia, or RET, is the RET gene, and we can see medullary thyroid cancer. So in general, other types of thyroid cancer like papillary is a more common one, typically not related to genetics, not hereditary, but the specific medullary type, which is very less common, can be an automatic indicator or red flag that this person maybe should be seen by genetics to evaluate, is there genetic testing that needs to be done? And there's just a few examples of some other starred indicators here that can be a bit of a red flag or pathognomonic. Okay, so in case I haven't been clear, hereditary cancer and risk development is complicated, right? On the left-hand side, we can see that multiple genes can increase the risk of a single cancer, right? Breast cancer can be connected to a dozen or more genes. And conversely, multiple cancers can be associated with a single gene. So we saw earlier with BRCA1 and BRCA2, breast, ovarian, prostate, pancreatic. And that's just an example of 2 genes. There are other genes that also have overlap for other different cancers as well. So it can be a lot of information. And that's where genetic counseling comes in. So somebody like myself, I'm a genetic counselor, so I'm specific training in genetics and communicating information about genetics and risk assessments to patients and other providers. We offer services in Ontario for those who meet certain criteria to talk about genetic testing or any high-risk programs that they might be eligible for, really evaluating the personal and family history to see, are we suspicious of anything or do we have any recommendations, and helping somebody decide what's going to be best for them. It really is a personal decision when we think about genetic testing or doing things like high-risk screening. So really, what is genetic testing? Well, it's usually done through a blood draw. That's how we look at the DNA and look at those genes relating to cancer risk. And we essentially scan along those cancer protecting genes or cancer risk genes, looking to see, are there any of those spelling mistakes or mutations that somebody was born with that have caused an increased risk or this predisposition to develop cancer. Now, in Ontario, we have specific criteria for who's eligible for genetic testing, and this is based on who has a higher chance of having a hereditary genetic cause or risk factor for cancer. If we'll go over some of those things based on what we've talked about today, and we'll touch on a bit more. If you think you might be eligible or somebody in your family, I do encourage you to speak with your doctor to see if a referral to a genetics clinic may be appropriate. Certainly, we cover the Erie St. Clair region, myself and our other genetic counselor, but there are genetics clinics across Ontario and Canada and the United States as well. So I encourage you always speak to your doctor, share that family history. In Ontario, if you do meet criteria for the genetic testing, it is completely covered by OHIP, so there typically is no out-of-pocket cost. Okay, so when we think about genetic testing and the types of results we could get back, there's really 3 different types. The first is a positive result, meaning it's positive we did find a mutation or a genetic change causing an increased risk for cancer. Now, the exact gene and mutation will tell us what cancer risks we're concerned about and how much risk there is. But for example, say somebody has an increased risk for breast cancer based on the genetic testing, well, they might be eligible for yearly mammograms and breast MRIs. Or like we just mentioned earlier, perhaps they'd consider removing their breasts to help reduce that risk for the future. Or another example, if somebody has an increased risk for colon cancer, Well, instead of doing that fit stool test at home, like most people over 50 do, perhaps we'd recommend doing colonoscopies every 5 years, just as an example. Having a positive result, while it's impactful for somebody's personal future with their doctors, it's also important information for family members. Because if someone's found to have a mutation, that means their relatives, like their siblings, children, parents, and extended family members, could also have that mutation and could benefit from knowing should they have genetic testing too. If they have that same mutation, they could be doing more for their health to be proactive and preventative. We could also get a negative result, which is what we call an uninformative result, meaning we did not find a mutation or a genetic change, or uninformative in that we don't have an explanation for why this person or the family has this cancer history. It's possible there is no hereditary genetic cause, it is just due to environment or lifestyle choices, or perhaps there is a genetic factor that our testing is just not able to pick up yet because we're going to learn about more in the future with more research. In these cases with a negative result, any recommendations for screening or treatment will typically be based on the personal and family history rather than this test because we didn't find anything. Now, for family members, what this means is typically we didn't find anything for one person, so we're not going to offer genetic testing typically for others, or it's not indicated because we didn't find anything. But if there are other people in the family who have personal histories of cancer that meet their own criteria for genetic testing, they may also be offered testing for themselves. There's a third type of result. It's what we call a variant of uncertain significance, or a VUS for short. So this means we have found a genetic change or a variant, but we don't have enough information yet to know, does this truly cause an increased risk for cancer? Or is this a completely normal, harmless thing to have? And it's not uncommon to get these types of results through genetic testing because we all have some genetic changes. That's what makes every person unique. It's just whether or not this specific change causes any health implications or problems. And most of the time, these VUS results, they do turn out to be completely normal or harmless. So that's typically the way we treat them. We don't make recommendations for these. We make recommendations based on the personal and family history, not this uncertain result. And really just encourage people to keep in touch with their genetics clinic to make sure they're informed about any updates over time. It's just like a negative result, because that's the way we treat this. Family members typically are not offered testing for an uncertain result, again, because it's not going to change anything for that person at this time, usually turns out to be completely harmless. Some testing may be offered in a research setting, or if a family member meets their own criteria for testing, they still might be eligible. Okay. So genetic testing, who's the best person to first have that testing? And let's walk through this example with our pedigree. So here's the person that first came to genetic counseling. And their father has colon cancer at 45. He has a sister who had uterine cancer at 38 and had passed away at age 45. And his mother, our patient's grandmother, had colon cancer at 42 and has passed away. So we do see some of those red flags we've talked about. We see cancers diagnosed at younger ages, young 40s, late 30s, as well as a trend with colon and uterine cancer, which we can see go together with Lynch syndrome, right? Endometrial uterine cancer, very similar, sometimes used interchangeably, not always. So automatically we're concerned there could be something going on here. Multiple generations affected, 3 family members, few red flags, thinking about that Lynch syndrome primarily. So looking at this family history, the best person to test is not actually the person that came to see us. It would be her father who had the colon cancer. Because if there's a mutation in the family causing this increased risk for cancer, well, we're most likely to find it in the person who's had the cancer we're suspicious about. That's why her father would be the best person. And if we do find a mutation for him, then we know exactly what we're looking for and you can do genetic testing for both his daughters. Versus if the father has genetic testing and we don't find any mutation, then there's no need for us to do testing for his 2 daughters because we didn't find anything for him. And if there was something, we'd be most likely to find it in him. So that's why we often make recommendations for somebody in the family who's had a cancer we're concerned about to be the first person to undergo that genetic counseling or genetic testing step. because it just gives more information for the person, but also for all of the family members. And certainly when we think of genetic testing and results and dealing with this information, there are challenges and limitations. One of those being is that we're continuously learning about genetics and our genes. So with some genes, we do have good guidelines on exactly what those risks are, what our recommendations are, what kind of screening somebody should be doing. For other genes, we might not have that information yet. So we might not have clear guidelines or be able to convey exact risks for something. It might be more, we're still learning about this and taking some precautions. One thing as well is with those variants of uncertain significance or VUS, they can be tricky to deal with because it's hard to think that yes, genetic testing has found something, but we don't have enough information to do anything or understand it fully yet, which can be frustrating both for patients and providers, and something that is complicated to talk about and share. And that's why having genetics teams, like a genetic counselor, a geneticist, a part of somebody's team of working on their genetic testing can be a good idea to help make sure information is shared appropriately. There can also be mental health impacts of genetic testing. Some people may find doing genetic testing and knowing there's an increased risk or predisposition for cancer is empowering. It allows them to be proactive and potentially preventative. Others may find the idea of knowing there's an increased risk in their life distressing and may not want to know that information and just prefer to go through life as it comes rather than thinking ahead. And it really is a personal decision if somebody's eligible for testing, whether or not they want to go that route. It is a very personal, and certainly genetic counselors, we are trained to ensure you make the best decision for you. There should be no pressure either way. It is a personal decision for you and your family. Another thing that's really nice is in Canada, we do have a law called the Genetic Non-Discrimination Act, which was founded in 2017. And this says it is illegal for third parties like a life insurance company or employers to ask about genetic testing results. So this information is extra protected. For example, life insurance companies, unfortunately, they can ask about personal and family histories of cancer, and you do have to be honest, but they can't ask about genetic testing results. So that's nice and protection and has allowed people to more comfortably have genetic testing if they're eligible and if they want to. Ultimately, it comes down for each individual, for balancing those benefits versus the risks and limitations. What's going to be the best choice for you? And keeping in mind, every family tree is unique. So it's always a good idea to be aware of your family history because that can help inform you in your care. So I challenge you, and this will be a worksheet that will be sent to you next week with those other resources. This is your homework, if you will. So I challenge you, go home, ask these questions with your family, create this list that you can be updated over time. We want to know who's had cancer in your family. Was it your sister, your grandmother, a cousin? Was it a cousin on your mother's side, cousin on your father's side? We want to know when and what. So again, who? I briefly went over this already. Are they a first degree relative? Parents, siblings, children's. Second degree would be one generation further or outwards. Nieces, nephews, grandparents, aunts, uncles. Third degree, cousins, great grandparents. Remembering as somebody gets further removed from you, less of an impact they have on your risk. Versus the closer they are, the greater impact they have. What is their primary diagnosis? What was the first cancer diagnosed for them, or where did the cancer start? That's what's important to us. Unfortunately, sometimes we find cancer when it has already spread to different places in the body. From a genetics perspective, we want to know where did it start and what can we call that cancer originally. And if somebody's had more than one cancer, was it a second new cancer, a primary like we've talked about, or is it the cancer's come back, it's reoccurring, or metastasis, it spread somewhere else? Sometimes we might send releases of information to somebody to share with family members so we can confirm these cancer diagnoses because it can inform eligibility and recommendations. We also want to know when. So how old was that relative when they were first diagnosed with that primary cancer? So if you think you are eligible for genetic counseling based on the information provided today, please talk to your doctor about a referral to our office. A lot of physicians in the area are familiar with our program and have our referral forms, But if you want to share, you're welcome to pass on our contact information. Your physician can always give us a call and request a referral form, which does also outline our eligibility criteria. And they can make that referral for you if it's appropriate. And this is just a little summary of what the steps are with our genetics program if somebody's referred to the cancer genetics program. Typically, we'll review the information on the referral. We may send a family history questionnaire for you to fill out that will go over personal and family history. We use that to review your eligibility for genetic testing or any other high-risk programs that we can recommend for you. If somebody's found not eligible, we'll send a letter back to the doctor indicating why not. And if somebody is eligible, they're accepted into the program where they will have a genetic counseling appointment, as well as a risk assessment, which is involved in that appointment. It will be determined, does somebody meet criteria for testing or not, and do they want to have that testing? If no testing's done, we still evaluate for any other recommendations like screening or eligibility for certain programs. If genetic testing is done, again, we would coordinate that blood work, and one of those three results is what we'd expect. Sometimes could be a combination of whether we find a mutation, find nothing, or find that uncertain result. And based on those results, we would again go over any recommendations, risks, referrals to specialists as needed, and providing support resources for that person and their family. And a lot of genetics clinics in Ontario might follow a similar model, but could be different and vary clinic to clinic. Okay, but before we get into just closing Renew and really just focusing on the talk for now, does anybody have any questions? And you're welcome to use the chat or unmute if you prefer. So I do have a question in the chat here. I had my genetic testing done and luckily was negative. My sister shares the same history and also has me, who I'm assuming also is like me, who had breast cancer. Would she be eligible for testing? Great question. And unfortunately, it depends. With the information you've given, I couldn't say for certain yes or no. If she's also had a breast cancer, I encourage her to talk with her doctor about genetic testing if it might be an option for her. Depending on your family history, it still might be. But if you've already had genetic testing, it might lower her risk, so we're less concerned. But certainly worth a discussion based on the family history, whether or not she'd meet her own criteria for genetic testing. Okay, so she didn't have cancer, but you did. So again, I don't have the full picture, so I don't want to make any specific recommendations for you. But if somebody in the family's had a cancer we're concerned about and they've had negative genetic testing, in general, this does give us reassurance for other family members because we didn't find anything for you. So those in the family who haven't had a cancer, we're even less suspicious about. But again, this can vary depending on what the actual family history looks like. There still might be enough other family history that we'd be concerned. But again, your sister is always welcome to speak with her doctor, share that family history. And I really encourage everybody to share their family cancer history with their doctors because this is good information for them and for you, right? Because that's only going to help you get the best screening and tailored management for you. And even if you're able to share other family history information like blood pressure, heart attacks, all of that can help tailor the best screening and care for you. All right, I'll just leave it open for another minute if anybody wants to unmute. Okay, I have another question in the chat box. What if there is family history of cancer, but those family members have already passed on? Good question. And sometimes, unfortunately, we do face these situations where those in the family who've been personally affected and would have been the better candidates for genetic testing have passed. Sometimes those who are unaffected in the family might still be eligible for their own genetic testing if that is the case. Sometimes they can be eligible, sometimes they might not be eligible. It really depends on the specific family history. If Shelley, if you do have a family history that you're concerned about after what we reviewed today, again, please share that with your doctor and to see if genetic or referral to genetics might be a good idea. Because it can be an option sometimes still, absolutely. All right, I don't see anything else coming over the chat, and nobody has unmuted. Okay. So lastly, if there's any questions or anybody's interested in getting a referral to genetics, here's again, the cancer genetics program for the Erie St. Clair region. Here's our phone number and extension. If you have specific questions or want to get a referral to our office and don't know how to go about that, this could be a good first start. But generally, speaking to your family doctor or your primary care provider, whoever that may be, is a good start to knowing, is a referral to genetics indicated. And just kind of some wrap up for the Renew session. So next week will be the last and final session for this season of Renew. It will be Eating for a Healthy Life with Anna Prestia DePonte. It's next Wednesday, so a week from today, same time, on the 6 p.m. on October 30th. It will be the same Zoom link, so you save that Zoom link for you. And just a friendly reminder to please complete the evaluations that will be sent to you via email. It really does help us know how can we best help everyone who's interested in these sessions. All right, and that's everything I had to share tonight. Everybody has a little bit of time back from what they may have planned for this session. So I hope everyone has a wonderful evening. If there are any, again, lasting questions or concerns, you're welcome to give us a call and we'll see what we can do for you. Okay. Have a great night, everyone.